Okay. Um, Momin sir has made my life a little bit easier because I'm covering what he has covered, and then we just put some flavor of the context and those certain scenarios of the cervical lymph node metastasis. Just going by 2-3 cases, and then we will realize how important it is to screen for the nodal disease. There was a 25-year-old PhD student, a left-sided neck painless swelling, and it was incidentally picked up by her sister 5 years ago, and then it was progressively increasing, causing some serious concern about cosmetic issues, and then there is some anxiety that there is some sort of swelling that is there. So there has been a previous workup, and if you see because it was asymptomatic pickup, it was evaluated somewhere in the north, and then we will see that it has been labeled as branchial cleft cyst on the left side, and then there is a thyroid 2 thyroid nodule. There is small nodule, and then she decided that she will take some opinion because her relatives are staying there, and because the diagnosis was branchial cleft cyst, it has been evaluated like an MR neck. And on MR, instead of labeling and ruling out branchial cleft cyst, it has been labeled as a lymphangioma. Like sir was saying that lymphangioma can also be one of the differentials. There was no mention on the regarding the thyroid nodule because it may be difficult sometimes to pick up small intralesional thyroid. She was advised sclerotherapy, but because there was ambiguity, she decided to take another opinion. At that time, then there is a referral that has been advised as a CECT. And CECT, they have reported a cystic hygroma. And then there was, we can see that there is a small nodule on the left of the thyroid, which is around 5 to 6 millimeter. We can see that there are cystic changes. There is some subtitions. There is some amount of tissue which is hyperdense, and then there are some microcal. But again, it has been labeled that this might all be a part of the cystic hygroma or other tissues. FNAC was advised because there was ambiguity among those MR, CT, and ultrasound. And FNAC is also advised from the cystic swelling. From cystic swelling, it was acellular proteinous as aspirate. Left thyroid nodule was Bethesda 2 colloid goiter. And in view of benign histological diagnosis, no conclusive evidence of malignancy, it was decided to put on active surveillance. However, the lesion continues to grow over the next 5 years to this size. She came here, tried to worried about that there should be no amount of malignancy that is there, and wanted to take an opinion because now the swelling is causing a concern. She want to get married and other issues. And then it came to the review. We will look at all the images. There was CT available, there was MR available, but there was no ultrasound that was available. So can we characterize these lesions or do stratify on CT and MR? Absolutely no. If it is concerned about thyroid, we have to look at the ultrasound, and then we'll try to do the risk stratification if they are entirely intra-lesional. Or the calcification does matter. What is the kind of calcification? Sir has already talked about many types of calcification that we can see in the thyroid tissue, and if they are microcal, they are actually of a concern. Whether the area which are solid, seen on the CT, subtle, even though they are small, 2-3 millimeter, whether they are having an increased area of vascularity, and shall we do an relook ultrasound? These are the areas, and whether everything matters, whether the biopsy was correct, whether the aspirate was having a clue and everything else. Again, repeat ultrasound was done. There was a tiny hypoechoic nodule, and if we now appreciate that there are some changes, some microcalcifications, irregularity, and infiltration into the surrounding tissue. If you see the node, then we can see that there are microcal, there are septations, another thing, and again it is coming as thyroid 5 category in those areas. So putting the subtlety and making everything together, there is a cystic swelling which is having a microcal. There is a possibility of cystic metastasis that is coming from entirely sub-centimeter size thyroidal tissue. Again, with this thing, it has went ahead. We did the surgery and we find out that this was entirely removable, and the final HPR shows papillary thyroid carcinoma, and there is a metastatic papillary lymph nodes. So the amount of confusion can arise definitely because cystic degeneration in the colloid versus cystic papillary carcinoma can have some ambiguity, and it requires expertise view in those areas, how we will try to triage these microcalcification. And sir has already enumerated about how we can actually differentiate between the comet tail and the microcal. And then comes about the hypoechoic nodules, whether the nodule is spongy form, whether it is having a posterior acoustic enhancement, or it is infiltrative, wider than taller, and other things, and that makes us worry. So there could be a misrepresentation or mislabeling in these settings, and that we should know about. So if we do a grayscale imaging and try to categorize whether these are spongy form, cystic, hypoechoic, and then try to characterize them and do a correct risk stratifications, and whether these patients will require FNA sampling, or maybe we have to integrate these into various groups. So what we do here is that we will take out all the entire details. Even when we are actually sending to our histopathologist, we will label each and everything. So what is our scoring system that is there, whether how is the kind of the aspirate that we are having, and then we are having blessed with the ROSE rapid on-site evaluation. Once cytopathologist is there, and they will tell us about whether it is adequate or whether it is matching our finding. If there is any thing that is not matching, we will try to repeat the FNSA in the same sitting. So finally, the issues and mysteries resolved around these patients. And coming to some theoretical aspects of it, that as sir has already mentioned, it is the level 6 and then level 3 and 4. These are the common site. The sensitivity of CT in picking up the node will be slightly better as compared to the ultrasound, and PET doesn't help too much in these scenario. So this is the triangle. Actually, when we talk about, this is the area where we should focus if we are actually concerned about the thyroid lymph node metastasis. If you go about the ATA guidelines, then the recommendations are like moderate regarding, we need to evaluate all these patients preoperatively with the neck ultrasound to look for any central and lateral compartment neck. And if there is any possibility of ETE and other thing, then we might undergo a evaluation with a CT scan. And if the nodes are actually bigger than 8 to 10 centimeter, then we should perform FNAC in those settings. And if there is an FNAC, then if there is availability of the TG washout, we should be doing in that. If the nodes are micro metastasis, which is less than 2 millimeter, they are not of a concern whether they are in the central compartment or in the peripheral compartment. And these nodes can be present in around 20 to 31% of these patients, papillary more than as compared to the follicular. And they may have cystic metastasis. This is something which we know that it is vascular, but it have a cystic metastasis, and there we can actually lag about, and it's having a very high odds of malignancy according to the ATA guidelines. So sometimes we see that these nodes are extremely rich vascular supply. There is one case in which has been labeled as a pseudoaneurysm arising from one of the mediastinal vessels. And because it was having such an intense vascularity, we try to perform an MRI. And we will see that there is no filling of the contrast into the dynamic flow on the MR angiogram, and it is just suggesting that it is just an metastasis, not as in a pseudoaneurysm. Again, we will see that if there is a significant nodal metastasis, we will do multiplanar coronal reconstruction to identify the location and the extent of the metastasis. And the coronal reconstructions will tell if there are clear fat planes, then it means it is not invading. In this case, it is the carotid. In here, it is the IJV where it is infiltrated by the tumor cells. This is again another question. It tells about that how indolent the disease might be there. The first case it was 5 years. This case was the 3 years. The patient only present when some complication or sudden complication will happen, whether it is a hoarseness or it may be in this case, it was a double vision, 15 days because of right rectal palsy. And we see that there is a metastatic condition that is there, and it was a tall cell variant of this carcinoma, and this will change the entire game. So which was thought to be probably resectable because it is involved in the cavernous sinus. RT has been given and the patient started on levatinib. MR might help when the patients are having some concern about the adenoated contrast or the raised creatinine levels, in that because of the high protein content on the pre-contrast, even these nodes can be picked up. and this thing, and we can actually sample all these nodes because some nodes are directly visible, but retropharyngeal and the deep intestinal nodes require CT guidance to map these things. So we need to know that where exactly the nodes can go, how the nodes will look like, what could be the location and extent of these things, how is the composition of these nodes, and vascularity and other issues, and how they are actually infiltrating into the surrounding structures. So with a keen eye for hidden clues, you can actually solve these jigsaw puzzles. Coming to the first case, when we started, in that case, it was initial presentation only mentioned about the neck swelling. There is no much more information that has been given. Radiology was labeled as in Thyroid 2, Bethesda, Thyroid 2, and that is leading to the multiple investigations, years of anxiety, financial burden, and may potentially lead to a wrong treatment. If you combine all these multidisciplinary systems together, then we will find out that it was a hard swelling. The radiology was Thyroid 5, Bethesda was Thyroid 5, and even though it is a malignancy, patient was happy to accept the diagnosis. So the careful observation of the findings and connecting the dots makes the lives of our patient better, and basic investigations like ultrasound can help in risk stratification, and then actually we can try whether we need CT further according to manage these patients. So thank you so much.
Thank you, Dr. Amit, for your excellent presentation and keeping it very brief. Are there any questions from the house?
Thank you.
Thank you.